My name is Dinka Vukovic. I'm a secretary of EDSA, and we are so pleased that we, through this our webinar this evening, will talk about early intervention. People who are involved in our associations knows that every year we have one topic for our AGA that usually held in this time of November or October. But this year, because of the epidemic situation, we will not have a meeting face to face, and we decided that we have several webinars and start first one with early intervention. I'm so pleased that we have this evening with us Sue Buckley, our professor, and our great woman who spend a lot of time to research and care about children and persons with Down syndrome. Professor Sue Buckley is really world's leading researchers in education and development of children with Down syndrome. She really is working so many years, and also she's involved in EDSA since 25 years. For us, it's very important that she also taking care about all our things what we have regarding education in most of our countries. As well, her work has been recognized through many awards, and many countries really share. Please said, yeah, big thanks to Sue and her team, what they did for all of us. Sue, please, you could start with your presentation, and thanks a lot that you accept our request that you explain to our families and our friends and our colleagues more about early intervention. Fulia, open the Sue microphone, please.
Okay. Well, first of all, can I say a big thank you to you all for inviting me and for attending this evening. And now I will endeavour to share my screen. Okay, so can you all see the screen? Yes, okay. Right, so what I'm going to do, and hopefully within about half an hour, or we're going to run out of time, is share with you my thoughts on what the priorities should be for the sort of early intervention that our organisations offer to people. And I'm going to go straight through in the order, roughly, that I think these should be priorities, summarise it at the end, and then take questions. Okay, now, when we think about early intervention, often the first thing we actually think about is improving the child's development. But I want to start off by saying I don't think that's where we should start. Okay. My experience is over many years, as Dinka said in the introduction. And one of the things I think we should always be focusing on is support for the whole family. It isn't a lot of good to give parents lots of advice on how they can help their children unless they've had time to adjust to the diagnosis that their baby has Down syndrome. And we think about how to support families, both at the start and as they continue through their journeys. So the first thing, of course, many parents want is accurate information. They're often at sea at the time of the diagnosis. They know something about what you'd expect for a typical baby's development, but when they know the baby has Down syndrome, this is usually a totally new situation. So positive and accurate information, which hopefully gives them some hope for the future. As you know, many families at the start find it very difficult to deal with the adjusting to the fact that their baby has Down syndrome. And then the important thing, of course, is that it's families that make the biggest difference to their children's progress. And in my experience over many years, of course, it's being fully included in the family. In the past, when expectations were low, Children with Down syndrome didn't lead ordinary lives. They didn't do all the things that other children should do. So it's really important, of course, to support families so they can go on living the life they planned before this baby with Down syndrome arrived. And the child can be part of a happy family, fully included in everything that goes on, and also not taking attention from everybody else in the family, not becoming what I've described as center stage, so that people always put the needs of the child with Down syndrome first. That's not going to support the whole family functioning well. It's also terribly important to be alert for families that are vulnerable. I'm sure you know there's quite a lot of research data saying families with Down syndrome do well. There's the work of Brian Scott Co and lots of people telling us how happy families are. They're not entirely representative surveys. About 70% of families do well. The ones not doing well don't take part in those surveys. They're not in big support groups. So it's really important to be alert for vulnerable families. And research tells us who they will be. They're people living in poverty, poor housing, single parents, isolated, no transport, and low self-esteem. They're not going to join your support groups necessarily. So it's really important to look out for them. And it's also really important to look out for families with more delayed children, because research tells us they fall into this vulnerable group. And in my experience, families with a new baby often get to join up with support groups, meet other families, and they begin to feel better and feel positive about their child. And then by the time the baby gets to 12 or 15 months, they realize it's not keeping up with the other children they know with Down syndrome. And then they often leave the support groups. So it's really important to look out for those vulnerable families. And where families have mental health problems, there's a recent paper telling us that when mothers have depression, it does influence the child's development. In this paper specifically, language development. Okay, so I'm really stressing we need to think about the whole family. And they're not going to be in a position to start doing intervention with their child until they've settled as a family and picked up their ordinary lives. The next thing, of course, is healthcare. And again, children aren't going to learn and make maximum progress until they're healthy. So if they're sick, it matters. And I think in most countries, you will have quite good guidelines now on early immediate checks for things like heart conditions and thyroid. But the next thing, of course, that often parents are often confronted with the need to deal with those health things. They find themselves in hospital with a baby who needs heart surgery, but also very commonly feeding and gaining weight are a worry. And so those things need to be addressed, and parents can't enjoy this baby in the way they would enjoy any other baby while significantly worrying about feeding. And then, of course, there's the ongoing monitoring. I've put here in vision and thyroid here. They're not the only things. And there are international guidelines, and hopefully all your organizations in your own countries have some influence on pediatric practices and make sure guidelines are in place for monitoring children's health. I've got on here also the issues about establishing healthy eating once children have settled with their feeding or got over periods in hospital. I've recently had correspondence with parents who've pointed out they've been very worried. For example, the child might have had leukemia or not been thriving early. And so they've been really worried about feeding them up. And then they get into the situation where they're now becoming obese in middle childhood. High proportion of obesity in our population. Children, at least a third of adults are obese and another third are overweight. Both for children and adults, it's an additional risk for being ill with COVID. Okay. Healthy sleeping patterns, really important. Poor sleep patterns have been shown to influence language, behavior, obesity, family stress. Some of that's been shown in children with Down syndrome. It's all been shown in children without Down syndrome. So some of these things about health really matter. And parents should not just assume sleep problems have to be put up with. And I'm going to say a bit more about that in a moment. And of course, as part of this healthy life, it's getting a healthy eating regime and not getting overweight and it's being active. And those things really matter for longer term health of children and all the rest of us, of course. Same problems in our communities for everybody else. And then the next thing I really want to stress is social development. And there are kind of two aspects to this. I haven't started off by giving you an overview of strengths and weaknesses in development. Most of you will know that social development and social understanding is a strength for most little ones with Down syndrome. They're not very much delayed early on in making eye contact, smiling, babble games, and so on. But one thing about this, of course, is it matters. Learning to talk and learning to communicate comes from that social interaction. And parents need to know it's a strength, that it's a really positive thing. Instead of getting a list of just the things that are going to be more difficult, it's important to stress that social interaction, play and communication are really important. And most youngsters with Down syndrome are really keen to join in. They're very focused on getting into social interaction with other people. So that matters. The other bit about social development is this message about self-regulation. Social development includes learning the social rules and learning to manage your emotions, learning to manage your behavior and fit in with the social expectations in your community. I'm sure I don't need to tell people listening to this that we have high incidences of difficult or challenging behavior amongst youngsters with Down syndrome. And we really need to think about this from the first year of life, because that's where it starts, okay? Learning to wait, not being picked up the minute you cry. By the time you're 3 or 4 months, that's really important. Learning to settle to sleep on your own, okay? And there's a recent study looking at sleep in little ones with Down syndrome, which I've mentioned here, which shows parents with little ones with Down syndrome, and these were toddlers, quite young, something like 6 months to 3 from memory. Parents of children with Down syndrome were much more likely to be rocking them to sleep, staying with them and so on, not leaving them to learn to settle to sleep on their own. That means night waking's a problem, because if they wake in the night, they want parents again. And they showed that this time that parents spent with them reduces overall sleep time. That's a problem because of the importance of sleep, okay? So there's huge amount of research on sleep and its importance for all children and all of us, increasing huge amount of research on sleep in children with Down syndrome. And we always think about sleep apnea. In fact, behavioral sleep difficulties are as important and very, very common, okay? Children don't want to go to bed on time and so on. And those behavioral things can be addressed. So it really matters that we think about sleeping routines, and parents realize they need that advice from the first year of life. Babies need to learn to settle themselves, okay? And of course, when we get sleep problems and behavior problems, we have lots of data to show it increases family stress, okay? So a bit more on behavior. I stress, and some of you may be surprised, that we really want to think age-appropriate behavior. And what I mean by this is following the big rules. So you can go to a restaurant, you can go to a play group, you can mix with age-appropriate children, you can go everywhere with your family without being disruptive. I don't mean that our children with their language and cognitive delays will understand all the subtleties and manage their behavior in quite the same way, but if we want them included, it really matters. And I've learned a lot from watching my daughter as she grew up and realizing she wanted to be out with teenagers. With teenagers, she wanted to wear her jeans and go to school sitting with the boys in the bus. She was behaving just like a teenager. And many of you will know she had very successful adult relationships in her early 20s and later. And I realized she needed to be able to get about socially and behave socially in a way that meant she could mix with her age group, okay? And you will also know the most common reason for inclusion in school to fail is behavior problems. Okay, so again, these are messages parents need to get very early. Have the same expectations. Managing your behavior starts with having standards for daily routines, for meal times, bedtimes, okay? All toddlers get challenging. And the sooner you're in charge, the sooner they realize adults run the world. And if you go to bed, you stay in bed and so on. It's much easier to start this when they're 6, 7, 8 months old than put it right later. Okay. So, and someone said to me recently, the most useful thing they ever heard me say when their child was under 12 months old was treat her like a sister, have exactly the same behavior expectations, don't make excuses, don't let grannies and aunties make excuses and treat the child as though they're younger than they are. You're doing them no favors, because they're going to go through life based on their age. They'll hit puberty the same age, they get out of school, and if you let them, they'll have ordinary adult lives based on their age, not their developmental age. Okay, so really, really important. And it's even more important that we think about routines, visual timetables, because we do know any child with really delayed communication is at increased risk for using behaviours to communicate. So really important. And it also builds on that message about social strengths. The children can understand and learn by imitation perfectly well. They can manage their behaviour fine if it's what everybody expects, and they set clear guidelines from early. Okay. And then this is probably where you expected me to start. It's really, really important, of course, to teach children to communicate. And many of you will know this is the focus of a lot of the work that we do. So, you know, it is really important that parents understand, again, communication starts early with that eye contact, smiling, babble games, taking turns, learning joint attention. So if you point to the dog and say dog, the child can look over there and know you're both talking about the dog. Early communication should be encouraged, and all those babble games, and keep talking to the child. Following their lead in those babble games, don't go too quickly, because it often takes them longer to organize a response. Imitate the sounds they make. That's one of the messages about following the child's lead. Give them a chance to join in, imitate what they do, which really encourages them to try doing it again. And within that, of course, it's important to keep talking. So they're exposed to a lot of input of your particular language pattern. One of the things people don't pick up on, including many speech and language therapists, is the research that shows speech really matters from very early. The brain tunes in to the language the baby's listening to from the very first weeks of life. And at about 4 to 6 weeks, babies can discriminate any sounds in any human language that's been tried. So Japanese sounds, Chinese sounds, English, French, Russian, whatever, Turkish, okay. They can hear them all and discriminate, but by the time they get to 12 months, they're now very good at discriminating sounds in the languages they've been exposed to and not the ones they haven't heard. The brain is tuning to the native language that babies are hearing, and what they can discriminate at 6 to 8 months and begin to produce predicts the first words they will try. And if you think about it, it's common sense, isn't it? So speech work is not just about developing sound discrimination and sound production for clear speech. It matters, but you can't learn the meanings of words. In English, think of hat, cat, mat, fat. They only vary by a single sound. If you can't discriminate those sounds, you won't hear the differences in those words. You have no hope of learning the meanings, okay? It matters for learning to understand language as well as say it. It matters enormously for the development of verbal short-term memory. The brain learns to discriminate the sounds in the language. Again, working memory just doesn't arrive in the brain. It's tuned up by learning about speech sounds and developing language. So it's really, really important, okay, as part of early intervention. The other things, if you think about it, I mean, we could have put some of these things in parallel. They all matter in the first year of life, okay? And they matter ongoing from there through the period of early intervention up to school age. Motor development, if you think about babies and their early development, the first thing they show they're learning about is social interaction. They're making eye contact, they're watching you, they're learning about people. That's the first thing they start to do. Then they begin to get some motor control, so they can reach out and pick things up, they can roll over and sit and so on. Hugely important. Typical children are learning through play and exploration. They need to be able to handle objects, okay? Debbie Fiddler's produced a number of recent studies highlighting this. Children whose motor skills are going ahead, who can explore their language and cognitive skills, are ahead of those who can't. Now, that's a tricky one because there's a wide range of individual differences amongst youngsters with Down syndrome. And so we want to be able to develop their motor skills, but we also want to think about compensating when they can't pick things up for themselves and hold them, putting things in their hands, helping them to feel, helping them to see how they can put something into something else, and so on. But we know in typical development that not only the hands matter, so you can pick up and manipulate things and find out what's heavy, what's soft, and so on, but being able to crawl and walk make a huge difference to your own ability to go and explore your world instead of being stuck on your backside somewhere. But as you stand up, people talk to you differently. Okay, and there's a whole literature on how these are milestones in typical development for social interaction and communication. So motor delay isn't just about motor delay, it affects everything else. All these developmental areas interact and influence each other. When they're little, there's a view massage may help, because with the small baby, it may be drawing their attention to where their limbs are and helping to stimulate feedback. Obviously, physio if available, and it'll vary in different countries and different areas of your countries. But the person who's probably got the most experience and written the most useful stuff is Pat Winders in the US. Recent papers with milestones for what we might expect in terms of development and different profiles of motor development in children, and her book on exercise. And one of the things she says is how important it is to make it fun. You want to encourage children to play. You can get them into positions to play. And I've given the example, of course, if you sit them up where they're not yet able to sit, if you sit them in a supported chair, it frees your arms up to play. So there are things you can do to get them into positions to play. And I've mentioned already, then thinking about compensating. The child who's sat on their backside, to go back to the social stuff, doesn't get out to the front door when the doorbell rings to see who's there. They don't get in the kitchen to be under mum's feet all the time, so she talks to them. Whereas a typical baby will be under your feet if they can crawl. Yeah. So not being able to move really alters your learning environment. So we need always to be thinking about that. And then a little bit more about teaching talking. Okay. And again, you would guess I could talk to you half the day about this, but children learn to talk. For all children, the quality and quantity of language they hear influences how fast they learn to talk. Okay, for all children. Now, the risk is that because our children are delayed and they're not starting to use their voices, they're not initiating and pointing and saying ook at the same stage. There's a real risk they get less input. And there are 2 or 3 recent papers suggesting that's the case. That it's hard for us to talk as much to our children when they actually need more input to learn. They're often getting less. Okay. And of course, many of you will know work from the state showing that vocabulary is learned in a developmental order, the work of the people who developed the communicative development inventory, showed very clearly, I don't know, about 20 years ago now, that children learn vocabulary in a developmental order, which reflects their understanding of the world. And then until they've got 50 to 100 different words, they don't start to join them together. And they need over 300 before they start to build sentences and express grammar. Now, those CDI checklists have been translated into most languages. So you should be able to find them. And the evidence is the same. It's the same in all languages. Those figures about how many words before you start to join them may be different in different languages, but the basic message is the same. We know that signing does help our children. There's a delay in being able to say what they know, that's speech motor stuff. But signs, many children don't learn a huge number of signs, but between about 2 and 4 to 5 years, signs do increase their ability to communicate. Okay. Once they can attempt words, the research suggests they learn new words in a spoken form. They know everybody else talks. Okay. So signs help, and they're often giving meaning to words. But we still need to be stressing, encouraging the child to make sounds and to use their voice. Huge variability in progress. And as you know, spoken language is one of those areas thought of as a specific difficulty because for most children, their spoken language lags behind their non-verbal ability. So a researcher in the States, Robin Chapman, described this again more than 20 years ago as a specific language delay. It's not just explained by slower cognitive development. specific language delay, almost certainly due to the high incidence of hearing loss. I glossed over that on the earlier slide, how important it is to compensate for hearing loss, because we know hearing loss predicts their language and their speech from research studies. Okay, so hearing's a big part of that, and then this verbal short-term memory, but they all develop together. Any child with significant speech and language delay will have a delayed verbal short-term memory system. And the pattern for our children is just like the group of children who get described as having specific language impairment, SLI, even though they don't have any other disability. Okay, the patterns are the same. So it matters hugely that you are making sure children get either speech and language therapy or lots of advice that you can provide on not just waiting for language to come, not just waiting for speech to come, but working at it consistently. Okay. And one of the things I should have said on the last slide is we think for all learning, the children need a lot more repetition. So a typical child will need to hear you say, oh, look, that's the cat coming into the kitchen over and over a number of days before they realize that thing's called a cat. Our children will need a lot more repetition, and it may be harder for them to isolate words in a sentence. So when you say, oh, look, there's the cat, whether they realize cat applies, there's a question mark over that. So more practice of learning individual words and making sure they're picking up the meaning. Okay. And then many of you will know one of the reasons I got into research was a dad writing to me about teaching his child to read in 1979. That makes me sound like a dinosaur. Okay. But we discovered from stories from parents they had 3 and 4 year olds who could remember sight words, and that we could use that to develop the spoken language as well as a basis for learning to read. And this goes back to my comment that that verbal short-term memory is a specific weakness, but visual short-term memory is a relative strength and mental age appropriate. So we want to use visual supports, signs, print, pictures, real objects. Whenever we're teaching, we want visual support. So we can use print like that. We'd start with words they understand already, teach them to read words for family names and things they understand. Once they can learn sight words, then you can teach new words in print and make lots of personal books. And I've put for all children there as a reminder, not every child's going to take off with their reading at 3 and 4. Not every child with Down syndrome is going to learn to read. We're talking about a very wide range of ability. All children will benefit from you making them personal books and reading them to them. And in many ways, the most delayed children are the ones where nobody ever does record what they're doing and what they're learning in books. But it's really, really important. And you can ask a bit more about it. So it's books for all children, even for those who are non-readers. Okay. But it's powerful for teaching children to begin to join words and move into sentences, because we know that's a challenge. Our children are often stuck communicating in 2 and 3 key words and not mastering the grammar and not learning all the words in the sentences. Okay. And somebody's going to ask me about the phonics. We would always start by teaching sight words and getting the children to show they can understand what they read. They can read 2 and 3 key words and put it on the right picture. So they're reading and understanding what they read by just developing a sight vocabulary to start with. And then the more words they can read, you can use that to show them that several words start with an M, they start with M. Words they can already read, you can use those to begin to show them how phonics work. And it'll be different in your different languages. English is particularly difficult because a lot of it's irregular. Some of you will have languages that are easier for the phonics, but it's still a complicated thing to understand for a child with cognitive delay. Okay. Now, teaching number of maths, again, I'm not going to say too much, but we would be starting that in these preschool years, of course, at 3 to 4. And many of you will know that many of our older children don't get very far. They find understanding, adding, subtracting, calculating, understanding money a real challenge, and they don't get all that far. And we think some of this is because we don't do the early teaching very well. We don't basically make sure they understand that numbers represent quantities. We do know from studies that having to say the words. I mean, the first thing a typical child does is learn to say 1, 2, 3, 4, 5. Our children will have difficulty actually saying those words and difficulty learning a list. That's that short-term memory challenge. Learning a list of 1 to 10 is a list of 10 words to keep in order, and so on. So we know there are going to be difficulties about just learning the count words and reciting them. But it's even more important, of course, that they know numbers represent quantity. We see a lot of rote teaching. Children who tell us the child knows numbers to 50 and they mean they can just read them off a number chart. They've got no idea what these words mean. They can recite them, but they've no idea 50 is bigger than 10 and so on. So we'd suggest you go very, very slowly, and you can look at our work on early counting. And currently we're trying to get the next 2 kits in the See and Learn program out. I'm working on the number stuff at the moment, but very important to go slowly and realize that the child knows numbers represent quantities. Okay. And then there are more difficult concepts that need to be learned. Of course, something's the same, it's more or less, bigger or smaller, and so on. So there are links with language learning and there are links with cognition. Understanding somebody is tall or short is not so difficult, but understanding that somebody can be taller than you or shorter than you, or you can be shorter than one person but taller than another is difficult. Okay, once you get to these comparatives, it's difficult. So there are quite a lot of challenges. I wouldn't be doing bigger and smaller with preschoolers, but you get the point. Okay, and again, it's lots of games and lots of repetition. Okay. And then what about key principles? If we're going to do any additional teaching, what are the things we need to stress? Well, one of the things we need to tell parents is what children with Down syndrome need most is simply good parenting. They need to be in a stimulating home where people talk to their children, play with them, do teaching games, teach all their children to count, encourage all their children to learn to read, okay? Good parenting. And that children are learning all day, every day, through all the times you talk to them, everything you're doing during the day, learning, okay? The reason I'm stressing that is I think because people like us are saying to people, do some structured teaching every day for half an hour. They put too much importance on the structured teaching and forget that everything else they're doing is teaching their child as well, okay, all day, every day. So it needs to be in context and remind people that when they're getting them dressed, when they're getting ready for school, all these are learning situations, yeah. So that they don't overestimate the importance of structured teaching and underestimate the importance of just the everyday quality of this child's learning environment and how they talk to them. So structured teaching will help, more opportunities, more repetition, short daily sessions where we know exactly what we're teaching and we're keeping a record in small steps of what the child knows. So we're doing it in a very precise and properly planned manner. Really important to use an errorless teaching approach, which means children don't make mistakes. You prompt them to be successful. So you show them in small steps what they're trying to learn by modeling and prompting, and then fade the prompts. Really important. Many of our children are really turned off. They'll throw materials on the floor. They really don't want to do things because they often do not understand what you want. And their immediate assumption is, I'm going to fail here. And again, they're highly tuned to failure. So it's really important to teach in a positive manner, small steps, prompting and prompting success. I've mentioned the using visual supports already, and that visual short-term memory is better. Modeling activities, our children learn by imitation, whether it's the structured teaching or it's learning social behavior by imitating the kids that they're with, where hopefully they're modeling good behavior. Not always, of course. And again, very important that it's fun, that we don't create learning situations that are stressful, because that is not going to help. So we can set up a structure where the child knows we're going to do some games, and so we're having some expectations we'll work through, but we're making it fun and making it success. Okay. And then the last point I want to make is inclusion. And this is a bit like the first thing about the family. If I were to reflect in the big picture, I've been working in this field for longer than I care to admit, in that I trained as a clinical psychologist and worked in learning disability in institutions before Roberta joined our family. And if I were to think now what's changed in the 50 years of her life, the big thing is inclusion, not being shut away. There was no right to go to school. There was no right to do anything when she was little. No services, no therapies, no nothing. You were just shut away. You're stuck at home with no school to go to, or you were in an institution. The biggest difference has been attitude change and inclusion, okay? In every sense, that kids are at home with their families, they're going to regular preschools and so on. That's hugely, hugely important. So it's not just about inclusion in schools, okay? But I do think the thing that's made the biggest difference is treating youngsters with Down syndrome as children first and people first. And we haven't cracked all of that. By the time we get to adult life, we continue to treat many of our adults like perpetual children. We don't let them grow up. That's for another talk, okay? But it's the child first. They should be getting all the same experiences as every other child if they're going to make maximum progress, and out there with peers. Children learn from other children things they don't learn from adults, okay? And you could think about that. So I really do think inclusion is hugely important. And it's back again to this big picture that the family's everyday life, what this child does socially, matter as much as the structured teaching, which matters and I think makes a big difference. But we need to keep that in a proper context. We know from many studies that inclusion in schools leads to better outcomes, provided the children are properly supported. The most common reason for inclusion to break down is the child's behaviour and people not understanding how to support that and manage their adjustment into school, to plan their curriculum and so on. But if we can make it work, we know it's the best place to be for our children and for changing attitudes to everybody else and for having children included when they leave school, getting jobs and so on. And Eric de Graaf and the Dutch Down Syndrome organisation, of course, have made a huge contribution. Eric's Gert has reviewed the research, and they've built on stuff that we did some years back on inclusion. So ensuring those many social opportunities are really important. You can only learn the social rules, that how you behave in church is different to how you behave in the classroom or how you behave in the pub or the restaurant. The rules are different, and we all pick them up by going there and subtly observing how everybody else behaves. You can only do it by being there. You have to be immersed in the social world to really pick that up. Okay. So to summarize the priorities, at least some time for questions. Families first, really important to take care of families and to watch that across the lifespan. Families who may be fine and be coping at one point may have difficulties part way along, and families need to know to ask for help too. And I do think that sometimes we are presenting a sunny and over sunny picture. There are families struggling, and very often in organizations, all those people who are active are the ones with all the resources to cope. We're doing okay. Yeah, we represent families who can get out there, find resources, cope. But a coping family might have a parent die, or granny who was an important support to the family die. So we need always to recognize we can go from coping to non-coping and look for help. So family support matters. And going back to that issue that the whole family matters, everybody's equally important. Okay. Healthcare, we've stressed, and I've alluded to the sleep issues. Recognize the importance of social development, managing behavior from the first year of life, support motor development, and recognize its influence on both cognitive and social development. Work on language, reading, and number, they all need to be taught. And then structured teaching matters, but it needs planning, and inclusion matters most. I mean, those are just the points I've just made. And now I'm happy to take questions. And I have also put on the end of here, and you've got them, they've been sent round to you. If you're interested, of course, on more on what I've said on speech or language and reading, you can follow this through. Lots of information on our See and Learn pages, including more on the designs of them. Okay. And obviously they might not work because you're all from countries with different languages, but the principles should work. Okay. So let's get rid of the screen sharing, and then you'll be able to see me, won't you? Hold on, what am I doing here that's not right? Hold on. Right, that's it. Okay, we've stopped screen sharing. You can see me now. Okay, So I'm happy to take questions. Very rapid presentation, but hopefully most of the ideas were put across.
Yes, so thanks a lot. Really, it was nice for some of us maybe repeat and to remember some things and refresh. And I think for younger families, it was very important to hear, even like you said, it's a short, but it's very important things what you said.
Thank you.
Now I would like just to say that we have participants from 30 countries. Just it's very impressive, and also we have 197 participants, but I don't know if Julia will say to us how many really succeed to be with us this evening. Now I would like
90.
to ask Anna to just go a little bit to the questions or comments what we have on the Zoom. Anna, please say a few words, and Julia, please open the Anna microphones.
Okay. Okay. You receive some comments and some questions. There is a question from Salvatore Caccamese. He asked, what do you think about the several assessments used to test the cognitive abilities of Down syndrome children and adults? Assessment measures, in my opinion, should include multi-test reset sessions for objective measures. What about the Cantab panel or short IBS test?
Okay. I don't think I'm in a position to comment on some of the specific tests that are used. But what I would say in general is most of the assessments designed for typical children don't have small enough steps. They've never been normed for children with Down syndrome, and they're not a good guide to things like educational placement or the learning abilities of our children. So we would be much more concerned that one is assessing developmental steps against what we know to be the developmental steps in each area of development. Like I alluded to language development, we know the order vocabularies learned. We would keep a record of the vocabulary the child's got and what they need to learn next, not some standardized assessment of their language. And assessments that end up with IQ type figures, I'd set fire to them. I don't think they're useful at all. Now, I know many countries' issues are different. I mean, in the US, it's really, really difficult. The children are assessed on these standardized tests, which don't tell you anything. We already know they're delayed for age. So I'm not sure if that's a really helpful answer. But I think what I'm trying to summarize is that assessments that were normed on typical children, you need to be very, very careful about how they're used, and that they're not relevant for setting educational targets or deciding where to place children in school.
Okay. And there is a question from Petra. I would be interested if there are any tips or literature how to learn a toddler to settle, fall asleep by themselves.
Okay. Well, yes, there is. I don't know that I can quote it off the top of my head, right? But there are studies looking at interventions, ways to help parents. There are. And so I think the most useful thing, I mean, I stressed, of course, prevention is the first thing, that if parents get this advice early, even just leaving a child to play when they wake for a little while and so on matters, not giving them immediate attention. If you have been staying with them, you probably want to work out a program of easing that off little by little. But there certainly are studies looking at effective interventions. And so I think what I need to do probably is find those and send you some references.
And fully ask, say, inclusion is better, but in pandemic, how can we make it possible? What are your experience and suggestions? Fully ask also experience of the other people from different countries, but we have no time to share. But if you have your opinion.
Okay, well, it's small steps, isn't it? And yes, here, the way we got going many years ago was simply to go and ask the child's local mainstream school if they would take them. We didn't try to change the system in any dramatic ways or close our special schools. We simply went to the school where their brothers and sisters went and said, will you please take them? And many schools just said yes. Now they need support. And now in the UK, it is automatic for a rising 5-year-old to go to the local school unless anybody says anything else. So over time, that's changed. But the other thing, and I think this has happened in lots of countries, is then finding schools that are willing to include children and then using those as models of good practice to encourage other schools. So what I'm suggesting is one way, of course, is going from the bottom up, just getting schools to take children. You need to be able to put some support in. So when I say we placed children, we also had the backing of our local education authority who funded assistance to be with the children in school. And we provided ongoing advice. You need a system for providing support. But also, of course, you can tackle it the other way around. And you will have just seen the document that Down Syndrome International put out on inclusion in education. And if you haven't, I'm sure you've all seen it. Down Syndrome International have just put out a document on inclusion everywhere worldwide, that it's a human rights issue, that most countries have signed up to not discriminating against children with disability, and so on. So you can go at it from the other end, the policy end, asking what's happening. But it's a prolonged battle. We don't have all our children included, and the older they get, the more likely they're to be out of the system. I've been heard to say if I was Minister of Education, I'd do what I think happened in Italy some years ago and shut all the special facilities. So you force it to happen. But there are not many countries that have done that. It's mostly a creaking system where you have to work at it based on your own local situation.
Another question from Monica. What is the link in your experience between autonomy and successful inclusion and vice versa?
Right. Well, I think by autonomy, you mean in the child's ability to be independent and to manage themselves. Well, obviously, the further they've got in that sort of independence, that they can use a knife and fork, feed themselves, take themselves to the toilet, hang up the coat, the further along they've got with that sort of autonomy, obviously it helps. But we have very delayed children included very successfully in many of our schools. Still being in nappies is not a reason to not go to school. You cannot discriminate because the child still needs toilet training from going to our preschool or school settings, okay? But obviously, the further along the child has got, the easier it is for them to be included. And overlapping with that autonomy question, the better autonomy, the better independence a child has developed, I'm assuming also they're better at controlling their behavior and knowing how to behave in different situations. And that really does matter. And these first 5 years are critical. They really do lay the foundation for what should follow. And that's why I think I've stressed a lot, thinking about a lot of these issues in advice parents get in the first months of the child's life. You're getting the right messages then will set them off on the right pathway. And we have very delayed children who do not have behavior problems. And we have very able children who have significant behavior issues. And I know which of them will have a happier adult life. Okay. The delayed child who can go anywhere with the family is going to have a better adult life than the more able child whose behavior is an issue. So it isn't, we're not just talking about the most able children when we talk about some of these critical things to think about. Okay.
The last question from Harris. I wonder whether the principles you mentioned in the presentation are applicable for all children with developmental disabilities, or are there some things that are specific for children with Down syndrome?
Okay, well, I think the first answer is probably yes, right? In the big picture, it's the same messages for any child with special needs, I think. I mean, these sort of developmental things like social development and behavior, they apply across the board. Any child with significant delay is at risk for some of the same things, but the things that are specific is there'll be other children who don't have speech issues or hearing issues. For our population, 80% of the preschoolers have poor hearing, okay? There'll be children with other kinds of developmental disabilities who don't have hearing and don't have difficulty with speech motor issues. So their language may be keeping up with their general development. So that profile of delayed verbal working memory and so may be more specific to children with Down syndrome. Yeah, and you know, the fact that we know visual supports are more repetition matter, but they will apply to many other children who have a label of cognitive delay or disability.
Yes. The questions are finished. There are some comments, and I suppose that the participants can read directly on the chat. And many thanks to Professor Buckley.
Yeah, and
I don't know if there are some questions on the Facebook.
Well, and I'm also happy if you want to send questions on to me. I'm not entirely suggesting, I did put my email address on the first slide. I'm not suggesting I'm terribly keen on 190 people all writing to me at once.
Okay.
But if you want to forward questions yourselves to me, I can reply back to you and you can share them again.
Okay.
So I'm happy to do that because I know we've done very well, haven't we? We've just stuck to the hour. But if there are things people really want to know, because I covered a lot of ground, which has probably provoked a lot of questions. Yeah, okay.
Thanks to Anna and Sue. On the Facebook, we don't have comments. We had 10 persons who watched on the Facebook. And Sue, yes, we could send to you some questions and comments what people had during the session. And if there are no other questions, I would like and comments, I would like to thanks first to Sue, to Professor Sue.
Pleasure.
Really, it was great pleasure to have you today with us. I would like to thank to all participants who come and spend this 1 hour with us to think about early intervention, to see what we could do in our near future and in our life of family, and also together within inside of the community. I would like to thanks to the Fulia and her team. They are in Turkey. Sue is in United Kingdom, Anna Contard is in Italy, and myself, I'm in Croatia. We tried this first our webinar to do as best as possible. I hope that we will see soon on the next webinar what we plan for the December in the similar time, and we would like to talk about research and what is going on in the area COVID-19 and the persons with Down syndrome. We hope that we'll have somebody from T21RS, and we are talking with them quite a lot how to prepare that next webinar. Webinar will be in the similar time, at the same time, most probably 16th of December. We are planning on that day, but we will inform our association, and then association will inform all of you who participate, and also we'll have information on our website of EDSA. Thanks to Cora, she's taking care for us EDSA website. Also we have on the Facebook, and we will send you information when we will have on YouTube channel. Thanks a lot to all of you, and have a nice evening, and take care.